Ma'am, I hope all have joined by now, or I shall wait for a few.
No. Everybody has joined. Welcome, Baldev sir.
Okay, so shall we start? Because it's 5 o'clock now.
Yes, sure.
Okay, sure, ma'am. We are starting then. Good evening and welcome to all the respected personalities present in this session. I am Rituparna from Clarnet. Clarnet is very proud to be a part of this webinar as a digital partner. Now, I would like to present before you a short video of Clarnet. Please stay tuned. Thank you everyone for all your patience. Clarnet is India's one of the largest live digital CME platforms generated by the doctors. Our website is www.clarnet.com, where we have lots of live sessions conducted by eminent speakers across the globe. And we also have our MedWiki services, which is a kind of medical Wikipedia for the doctors only to be accessed. I proudly invite you all to read and go through them in your leisure time. We will invite all the doctors to visit our website. Now, without any further delay, I would like to quickly hand over the session to Dr. Neha. Over to you, ma'am. Please continue.
Thank you so much, Rituparna, and thank you, Clarnet, for providing this platform to us. And I welcome all of you to eGurukul Pathshala PG Clinic, which is a very popular program in all the PGs. Today, we have a different program, that is stable viva on cardiovascular system, X-ray and ECG. For today, we have two eminent experts with us. One, Dr. Divyesh Sadadiwala. He has rich experience of 10 years in the field of pediatric cardiology and has treated thousands of patients with the congenital and acquired heart disease, arrhythmias, and grown-up children also with the CHDs. He did his graduation and post-graduation from the Government Medical College, Surat, and he was gold medalist in MD Pediatrics. He has done his fellowship in the pediatric cardiology from Apex Cardiac Institute, Narayan Hridayalaya, Bangalore, and stood first in the exit exam of the fellowship among all the fellows. He is working as a pediatric cardiologist at SIMS Hospital, KD, SGVP, and Narayan Hridayalaya Hospital in Ahmedabad. Welcome, Divyesh bhai.
Thank you, Nehal ma'am. Thank you, Clarnet, for inviting me in this very interesting kind of session. I always like this kind of teaching modules where you get opportunity to interact with residents, because that is my favorite thing, to teach residents. I visit LG Hospital also, and there is a gang of residents at LG Hospital. So we frequently hold this kind of sessions at LG also. So hi all residents. In today's session, what we will do is
Divyesh bhai, 1 minute. Yeah. I need to introduce Bhadra sir also and participants. Sure. Then I will hand over to you. So we have another eminent expert with us, Dr. Bhadra Trivedi. Sir has completed his MD Pediatrics from the Sumandip Vidyapith in 2012. And he completed pediatric cardiology fellowship from Narayan Hridayalaya under Rajiv Gandhi Health Science University in 2014. He worked at the Fortis Hospital, Mumbai, and then Wockhardt Hospital, Mumbai Central, as a pediatric cardiologist from 14 to 18. And then he joined Sri Krishna Hospital, and at present currently attached as a consultant pediatric cardiologist in Sri Krishna Hospital, Karamsad since 2018. Welcome, Bhadra sir.
Thank you, Nehal ma'am. Thank you, Baldev sir and Divyesh, for making me part of this team. And I don't have as much experience as Divyesh has. I mean, I was always laggard in his GMCs as well as in
me and Bhadra are colleagues. Me and Bhadra are colleagues in medical GMC Surat.
So yeah, I follow him. He left to Karamsad and I joined Karamsad. So yeah, but anyway, I'm glad to be part of this initiative. I'll be happy to contribute to whatever I can in field of ECG with my resident colleagues here.
Thank you, Badra sir. We have participants, Dr. Sailusha, Dr. Satakshi, and Dr. Manali from BJ Government Medical College, Pune, and Dr. Kailash and Dr. Gunjali Shah from MP Shah Medical College, Jamnagar. All are third-year resident, and I welcome all of them to this platform with a new experience, except the case presentation today as the table viva. As a participant, all the students and two experts as a moderator. And today, Dr. Baldev Prajapati, who is teacher of teachers, he is there to guide all of us through a new experience. So I welcome all, and welcome Baldev sir also. Sir, few words from you. I think sir has left.
That's muted.
So sir,
Voice.
sir, you are muted, sir.
Your voice.
Sorry, extremely sorry.
Yes.
Good evening, friends. What I was talking, that first we should decide the flow of the session, because it is in a different way. Commonly what we do on this platform, that we go for the case discussion. And for that case, there is one presenter. He starts with the history part that we discuss, and later on the examination and ultimately the investigations, and the whole case is developed. So that's, I will say, different methodology in the case discussion. I think here in this table viva, or at least X-ray and ECG in cardiology specifically. So I think in what way you have planned, just you can share, or otherwise I think if you are divided, that suppose Dr. Divyesh has some cases and Dr. Patra, then at least they can present at least the case or put some questions. We can interact with the students and ultimately come with these final answers so that they can at least remember, and it can be helpful to them in the exam. I think here that we'll have to modify the way of this conducting the session. Am I right? Or
Yes, sir. So, sir, we have planned like X-ray part. Some slides will be done, and explanation will be done with your comments by Dr. Divyesh. And then there are some X-rays on which the students will also comment as per your and Dr. Divyesh's questions. After that 1 hour part of X-ray is finished, Dr. Bhadra Trivedi will also guide with some of the slides of the explanatory for ECG, and then again student interaction with you and Dr. Bhadra Trivedi.
Okay, I think what I will suggest, Dr. Divesh, that you can suppose whatever you have some presentation of some case that before suppose X-ray, that this was the some case presentation, that history part 2 or 3 salient features, and this is the X-ray. Then we can ask the students, we will interact, that let the students interact. That is more, you will say, important, rather than you speak or I speak.
No, sir, I have kept like that only, sir.
Yeah, and once they interact, even multiple students, and there is some mistakes or some wrong, different interpretations, then I think you can, or all of us can correct one by one, and they can go, keeping in mind the timing and whatever I will say X-rays you have. Accordingly, I think we can just start the flow. Right.
Sure.
And I wish and I request, number one, all the students keep their video on. Number one, I think an X-ray should be seen. Similarly, your face should be seen.
Exactly, sir.
And I think, then I think we can interact.
Very valid point.
Second thing, freely we should interact. Even whatever comes to your mind, without any hesitation.
No, we will speak minimum, sir. Let them speak.
Yeah, suppose something is wrong, they will correct us. No problem. But unless we speak, probably nobody can learn. So without any hesitation, freely, everybody should participate. I think some question is there should be 4 or 5, I will say, hands rather than one person. And I have not to ask somebody that Gunjali should say or somebody else should say, right? I think spontaneously you interact from yourself. I think I'm sure that it should be quite interesting for 2 hour session. And with that, I request Dr. Divyesh probably is the first to start it. You can just start it, and I'm sure that the gradual will develop the interest of all of us. Thank you very much. Please go ahead.
Is this slide visible to everyone?
Yes, yes.
Okay.
Dr. Divesh, can you
So,
make it full screen?
yes, sir. I've done it, sir.
Yes, yes. Now it is seen. Yes.
Okay, sir. So, good evening. We will start with the X-ray part, and Dr. Badra will take over from ECG. So, what we'll do first is I will brief you what to look in the X-ray when you are looking for cardiac diagnosis in chest X-ray. So, after those few slides, we will go over for the spotters. So whenever you are looking for cardiac examination in a chest X-ray, these are the parts that you have to see. So these are the parts which make the cardiac silhouette. The left border is formed by left ventricle. The upper border is formed by left atrium and left atrial appendage. And above that, there are great arteries. This is pulmonary artery. Then there is aorta. Similarly, on the right side, the right atrium forms the majority of the border of the right heart. Superior vena cava is there, inferior vena cava. So these three parts form the right silhouette of the heart. Surprisingly, you notice that right ventricle doesn't form any of the cardiac silhouette. So many a times, whenever you find any diagnosis where right ventricle may be enlarged, you will not look for the apex. You will look for the uplifting of apex, because when right ventricle is enlarged, it will uplift the apex of the left ventricle. It will not form any border. So you will not see it is a RV kind of cardiomegaly, but it is because of uplifting of apex, we will get indirect idea that it is a RV kind of cardiomegaly. How do you decide cardiomegaly? So you have to take the maximum cardiac diameter on the right side. Then you take the maximum cardiac diameter on the left side. You combine those two, and then A plus B. After that, you take the maximum thoracic diameter. So if A plus B is more than 0.5, more than 50% of C, then you label it as a cardiomegaly. In left atrial enlargement, what will you see? You will see straightening of left heart border, because it is formed by left atrium and left atrial appendage. You will see uplifting of left bronchus. And very peculiar, you will see double density shadow, because LA will push the RA border. So you will see two borders. It is called double density sign. So this is LA enlargement on X-ray. If left ventricle is enlarged, you will see rounding of apex, because majority of the mainly apex is formed by the left ventricle. So whenever LV is enlarged, you will see rounding of apex, and apex will be shifted down and out. Most of the times with LV and LV enlargement, you will see left atrium enlargement also. So again, L enlargement signs also will be seen. Plus in pediatrics, most of the times along with LV enlargement, you will see pulmonary hypertension. So you will see pulmonary plethora, dilated right pulmonary artery. So these are associated findings in LV enlargement. In RA and RV enlargement, as I told you, you will not see any changes most of the times in apex, apart from some uplifting of apex. Mainly you will see RA enlargement, and you will see it as a prominent shadow or increased shadow or increased enlargement on the right side of the heart. You will see prominence of main pulmonary artery, because most of the times with RA and RV enlargement, you will see pulmonary artery enlargement also. Then most of the times we don't focus on the great arteries. So I would like to tell every resident that most of the times whenever you are looking for X-ray, you see the great arterial connection, you see the great artery, what is happening with great arteries. So pulmonary artery, if it is enlarged, you will see prominence of pulmonary artery knuckle. If pulmonary artery is hypoplastic, you will see the absence of pulmonary artery knuckle. If ascending aorta and aortic knuckle is enlarged, you can say because of that ascending aortic aneurysm or any other aortic abnormality will also present, and you can label it from X-ray. Next important part is pulmonary vascularity. So most of the times we just focus on the lungs. We don't see what is happening with the vessels. So these are the 3 slides which will help you in deciding the vascularity. The middle one is normal vasculature of the lungs. If you are able to see the vasculature till 50% of the thorax, then it is a normal vasculature. If your vasculature is extending towards extremities of the lungs, then it is increased vascularity. And if you are not able to see 50% of the lungs also, then it is oligamic or low vascularity of the X-ray. So I think these are the basic slides which we have to see from chamber enlargement, great arterial shadows, vascularity. After this, we will go ahead with the spotters. So, sir, I think we would start with one resident, or we would, in general, ask them.
I think you can put the question generally. They can raise their hand.
Okay. Okay. Sir. So this is a
or by turn you can ask everybody.
Okay, sir. So I think this was a 4-year-old child who came to OPD, and pediatrician found some abnormality in the heart sound, and he had some lung findings also. So he decided to get the X-ray done first. So this is the X-ray of that patient. So anybody would like to comment on this X-ray? Dr. Rajat, we will start with you. First thing, you have to tell whether cardiomegaly is there or not.
Sir, there's no cardiomegaly.
Okay. Anything
There's
else?
prominent bronchovascular markings.
Okay, it is increased vascularity or it is normal vascularity?
Increased vascularity.
Increased vascularity. One more point I would like to tell you here is, whenever you see vascularity, you have to see the vascularity going downwards, shifting downwards or going upwards. It helps you in differentiating whether it is arterial congestion or venous congestion. Whenever you see vascularity and you see it is going downwards, it is mostly arterial congestion. So it is happening because of increased pulmonary vasculature, because of left to right shunt happening inside the heart. Next, what else?
Prominent pulmonary knuckle.
Okay, good, very good. What else?
And there's a straightening of the left heart border.
Okay.
I think, Dr. Divesh, I will request you that whenever he speaks, at least you can try to show on the screen,
yes,
so others can follow it. That where is the pulmonary knuckle?
This is pulmonary knuckle.
Yeah. So that, yes, they can understand that this is pulmonary knuckle. And the straightening of border, he said, so that he wants to show.
What else?
Even anybody else. Suppose something comes to your mind.
Are you able to see increased or
Right,
RA enlargement?
right atrial enlargement.
Right atrial enlargement is there. Okay. So to summarize, a 4-year-old asymptomatic kind of patient growing well without any major symptoms is coming to routine OPD. Pediatrician is not able to auscultate any peculiar murmur, but there was some abnormality in the heart sound. He got the X-ray done, and this is the X-ray finding. So in X-ray, to summarize Dr. Rajat's findings, there is no cardiomegaly, there is some right atrial enlargement, there is prominence of pulmonary artery, and there is increased vascularity. Correct? And there is straightening of left heart border. So putting all these things together, Dr. Rajat, can you give me some probable diagnosis? What in which heart condition you will find all these things? Asymptomatic kind of patient with right side heart enlargement and increased vascularity in the lungs.
VSD.
Which one?
So most likely VSD.
VSD. Dr. Kailash was saying something else. ASD. Okay. So in VSD, right atrial enlargement will happen or left ventricle enlargement will happen? Dr. Rajat. He is left. Yes, Dr. Gunjali.
Yes, sir.
In VSD, LV enlargement will happen or RA enlargement will happen?
Sir, left sided heart enlargement in the
Okay, why
VSD.
does it happen?
Because in the VSD, sir, due to the left to right shunt, the more flow will go to the pulmonary artery, and from there the blood will come to the left heart. So that's why the left heart enlargement will be both left atrium and left ventricle. And in
So
the severe,
doesn't the same thing happen in ASD also?
no, in ASD there is a right-sided heart enlargement, sir, because
Why?
there is a shunting of the blood in the atria. So the blood will enter the right atrium from the left atrium, and from the right atrium the blood will go to the right ventricle, and from there to the pulmonary vessels. So the blood is going to the right side of the heart. So there is more likely
But
chance.
isn't it going to lungs also?
But sir, there is direct transmission of pressure in the VSD from the heart. That's why in the
So
ASD.
main crux is the shunt happening before tricuspid valve will not have the pressure.
Yes,
Shunt happening after the tricuspid valve will be happening with pressure.
with pressure.
So what happens in VSD is left to right shunt, all the blood just RV is just happening, just working as a conduit. It is not holding any blood. So all the blood from right ventricle directly goes to the pulmonary artery. Then from pulmonary artery, it goes to the pulmonary vein. So main holding of the blood happens at the pulmonary veins. So first thing starts getting dilated is pulmonary artery, and after that pulmonary veins. From that pulmonary venous blood will enter into the left heart of the left side of the heart, and because of that LA and LV will be the holding chambers of that high pressure blood. So that's why you see LA-LV dilatation. In ASD, it is completely different scenario because the shunt is happening at very low pressure. RA, right atrium and right ventricle, they are probably more than right ventricle. Right atrium is very compliant kind of chamber. It can hold huge amount of blood. That's why when patient is in shock, you see IVC and RA, and then you push the fluid because RA will hold good amount. If RV function is good, you push more amount of fluid. So in ASD, holding happens at RA and RV level. So that's why in ASD patient, you will not face any heart failure symptoms. That is the main reason, because the shunt is happening at low pressure. Your pulmonary venous system is not coming into picture. Everything has been done before the pulmonary veins come into picture. Okay. Got it, Dr. Rajat?
Yes, sir. Yeah.
So what is the probable diagnosis? Atrial septal defect.
Yes,
Can anybody tell me what was the abnormality of heart sound that pediatrician picked up?
slow murmur at the pulmonary valve.
Okay. Before that, what is the diagnostic part of ASD on auscultation?
ASD, sir.
Yes. What will clinch the diagnosis if flow murmur is also not there? What will clinch the diagnosis in atrial septal defect?
So white fixed splitting of the second heart sound.
Correct. So whenever you find white fixed splitting of second heart sound without any murmur, the diagnosis is made of ASD. In ASD, the flow murmur happens in this age only, 4 to 5 or 6 to 7 years. Many a times we pick up ASD in second or third decade also. That is the main reason that ASD will not cause any murmur. So you have to look for wide and fixed splitting of second heart sound in ASD. Next slide.
I think, Dr. Divesh, before you go for the next,
Yes, sir.
let me remind the students, when X-ray is kept in the examination, is not, I will say, told that whether it is related to cardiology, respiratory system, or some other system. Right. So the point is, first you will have to read the methodologically. Here probably when Dr. Divesh is asking, probably you are clear that condition is related to the heart. Exam not necessary. Some of the cardiac features also may be the secondary to the even basic condition. Suppose many a times you may get that the heart is pushed on the opposite side, but may not be the dextrocardia, maybe due to something else. The point is, always X-ray chest should be read. I think here I will not take the much time. Last week only I have taken GCS for 3 hours the radiology X-ray session. And then how the X-ray should be read, even chest X-ray simply I'm talking. Look at this even first, always the skeleton. Look at the domes of diaphragm. Look at even the trachea. Look at the then cardiac shadow and even the lung fields. Never miss to see even the upper part of the abdomen. That will also provide lot many info, even in the cardiac condition. Suppose anomalous pulmonary venous return, you may get some shadows even in the part of the abdomen also. So the point is, it is very important. Simply somebody will ask, suppose, Dr. Divesh, can you go in the previous X-ray? Previous slide.
Yes, sir.
Okay. Anyway, I think any X-ray, I don't mind. Suppose this X-ray. Somebody will ask whether this X-ray is taken in the erect posture or the lying down position. Dr. Gunjali?
Erect postures.
Why?
Uh,
From where point you are catching that it is the erect posture? And you know that also makes difference in the cardiac shadow even. Lying down position and erect posture. That also makes
lying down position, in the lying down position, the heart shadow will
no,
be more spread out.
here my direct question. Why did you say it is in erect posture? From which finding? Anybody else? Dr. Rajat or I think Dr. Kailas? From where you will have to see? From which you can say that it is in the erect posture or lying down position?
Sir, in the lying down position, the diaphragm will be more upwards in compared to the erect posture. So
Okay.
here, as the lung fields are hyper, I mean, we can see more than 6 rib spaces. So
I
the
think
diaphragm.
I think here I will not be able to show, but I am sure that Dr. Divesh will show where is the gas shadow in the fundus of the stomach.
Yes.
I think here there is this gas shadow, right? And you know when the person is in erect posture, gas in the fundus of the stomach will come just below the diaphragm. And in the lying down position, it will be dispersed with even the other contents of the stomach. So simply from the erect posture, and that can make difference, as you said very rightly, regarding the contour of the dome of the diaphragm, regarding even the cardiac shadow, and so many. Even sometimes, diaphragmatic hernia, very common condition in pediatric practice. That apparently, if you see, it will show the dextrocardia. But if you try to even focus that, oh, something is there on the left side in the lungs, and then you may be diagnosed. So I think the point is, we'll have to learn methodologically the interpretation of X-rays. Here, very rightly, I think Dr. Divesh explained so nicely that how the various, even the shadows in the right border, left border, and up, even the vessels you can identify, and accordingly you can go for the cardiac condition. Thank you very much. I think we will not take time in every case, but I'm sure that some important features will take it. Dr. Divesh, go ahead, please.
Yes, sir. This is the next X-ray. This is a 2-year-old kid who had come to OPD, and pediatrician was able to pick a loud grade 3/6 pansystolic kind of murmur. So echo facility was not available. Child was having decent weight gain. At 2 years, he was weighing around 10.5 kg. Child had not any episodes, many major episodes of hospitalization also. So he thought, let us get the X-ray done first, and this is the X-ray. So Dr. Manali, would you comment on the X-ray?
Sir, in this X-ray, we can see the lung fields are plethoric. Also,
Okay.
the left ventricle seems to be uplifted. Also, the pulmonary bay, that area pulmonary knuckle is prominent, so it is indicating the overfilling of pulmonary vessel. And as the history told about the grade 3 pansystolic murmur, and it is a case of VSD.
What did you tell about LV apex?
So it seems uplifted.
Uplifted, or it is down and out apex?
Yeah.
Okay, it's prominent, sir. It indicates ventriculomegaly.
So when if you are commenting about apex, you should be very much particular. The uplifting of apex, you will see the prominence of apex in this part, because the LV is pulled up because of RV kind of hypertrophy or RV enlargement. If your apex is down and out, pointing towards your costophrenic angles, then it is LV kind of apex. Okay, so your history, your examination of the X-ray, everything is pointing towards left-sided of heart enlargement along with increased vascularity. So your diagnosis?
VSD.
VSD, but mostly it would be a moderate kind of VSD because child is 2 years of age. Child did not have any major hospitalization. Child is having a decent weight gain also. So it would be moderate kind of ventricular septal defect. Any comments, sir?
No, I think you can go ahead, please.
Okay, sir. So continuing with this flow, the next slide, who would like to take up? Dr. Shatakshi.
Good evening, sir.
Hmm.
Sir, there is cardiac enlargement.
Correct. What kind of cardiomegaly is there?
Sir, left-sided, the apex looks down.
Down and out. Yeah.
And sir, there is also straightening of left heart
Very
border.
good. Very good.
Sir, then there is also prominence of aortic like vessel, and on the right side also the right border is prominent, and prominent bronchovascular markings on the meter 2/3 is there.
Okay. Can I ask you one thing? What is this? Dr. Bhadra has also pointed something. We will take that one also. But my question, what is this thing? Is this a pericardiac consolidation? Dr. Shatakshi?
Yes, sir.
Is this a pericardiac consolidation?
Sir, it can be a shadow also.
What part of the heart or body will form this kind of shadow?
Sir, right atrial shadow.
Right atrial shadow will come here. Right atrium will not come here.
Okay, sir.
This is right atrium.
Okay.
What is this? Because this is the most overdiagnosed kind of thing on X-ray, right pericardiac consolidation. That's why I wanted to draw your attention towards this thing.
Sir,
so,
is it thymus?
No, it is not a thymus. Thymus will come here in upper mediastinum. This is in between your thoracic lung field. And as I told you, when Dr. Rajat was describing the first X-ray, whenever you are looking at the vascularity, what do you see? Going down or going up? What is this?
Going down. Going down.
Are you able to see any air bronchogram here? Are you able to see any air bronchogram? Anyone? So this is not a pericardiac consolidation. Whenever you see cardiomegaly, whenever you are suspecting any left to right shunt and you see this kind of shadow, this is right pulmonary artery. Because of increased vascularity, RPA will be enlarged, right pulmonary artery will be enlarged, and it will form this shadow in most of the X-rays that we look ahead now. We will see this X-ray in 90% of the times, whenever there is increased vascularity. LPA will not be seen because it is retrocardiac. So whenever you see a right lung field and this kind of shadow, most of the times, along with increased heart size, it is right pulmonary artery that is forming this shadow. Clear? Now, Badra sir's questions. What is this? Necklace.
Maybe patient has been operated for some, and the clips have been placed for the.
Very good. So these are the sternal clips which are placed after surgery, open heart surgery. We do mid sternotomy, and then to close that sternum, these are the clips that are used. These are the stainless steel clips. These are used to fuse the sternum. So diagnosis, Dr. Shatakshi.
Sir, it can be, sir, what is the age of the patient?
Age of the patient is 5 months.
5 months.
Yeah,
So,
weight is 4 kg.
sir, it can be, sir, it can be TAPVC.
TAPVC.
Sorry. Sir, it can be tetralogy of Fallot.
These are the things that will
No, sir.
divert your viva to another level. You are saying you are having 5 months baby who is not gaining weight nicely. You are able to see left ventricle enlargement. You are able to see increased vascularity, and you are saying TAPVC. TAPVC doesn't fit in this diagnosis at all.
Okay. Sir, it can be a very large VSG.
Very good. So any post tricuspid shunt happening after tricuspid level, large VSD or large PDA also, or large aortopulmonary window also will form this kind of shadow in the heart. With history in the background, child is small, child is having difficulty in gaining weight. You will be having some other features of also of congestive heart failure like suppressed cycles, history of LRTI. So all these things will point towards the diagnosis of large shunt. So VSD, mostly large left to right shunt. Badra sir, can you remove this annotation? Chalo, next one. Dr. Kundan.
Yes, sir.
Yeah.
So there is a cardiomegaly.
Very good.
And
whenever you
then,
describe the X-ray and you say cardiomegaly, you have to give probable estimate of CTR also, cardiothoracic ratio also. So cardiothoracic ratio of around 60 to 70%, that would be fair enough. Nobody expects you to go and measure the heart size, but at least if you can give a rough estimate, that also will be sufficient enough. So what is your estimate? What is the heart size here?
it is like more than 0.6 kind of thing, sir.
It is
Like
almost
cardiomegaly.
70%. 70% of the thorax is being occupied by the heart. Am I wrong or right? Okay. Chalo. Now apex.
Yes, sir. Yes. Apex is like uplifted kind of thing, sir.
Uplifted?
No, it
now,
is shifted and downwards.
I think all of you are finding it confusing to what is uplifting and what is down and out. So always try to see where is the maximum prominence of the apex. Where is the maximum prominence of the apex seen? It is seen here or it is seen here?
Still lateral, sir.
Here, down and out. More,
Yeah, down and out.
After that, you have to see whether any space is left here or not. Whenever there is LV kind of cardiomegaly, it will try to invade all the space that is in the lateral thorax. So you will see very minimum space being left in this costophrenic area. So try to remember these 2 points. Second thing, whenever there is uplifting of apex, you will see the apex forming like this. And to be very frank, uplifting of apex or RV kind of cardiomegaly happens in very limited situation. We will see that X-ray also later on. But whenever you are seeing this kind of X-ray and you have to see whether apex is shifting down and out or not. This is very clear. I don't think any confusion is here. It is down and out of kind of apex. Chalo, next.
And the RA hypertrophy kind of thing, sir.
RA is also enlarged. What else? What is
Then
happening
pulmonary oligemic kind of thing.
Oligemia.
A plethora. There will increase pulmonary blood flow kind of.
Okay, I think you confused the words.
Plethoric kind of thing.
Plethoric lung field. So this is 6-month-old patient. Weight is around 4.5 kg. He had episode of 1 LRTI. Was admitted for 7 days in the hospital, and now he has come again with the symptoms of fast breathing, difficult feeding, and there are congestive lung fields, and there are some signs in the lung also. So they wanted to rule out whether it is because of LRTI or because of it is congenital heart defect. So what is the diagnosis here?
So like post tricuspid shunt with increased left to right, like PDA, large PDA can be, or a large VSD also.
Very good. So it is again the same scenario that we have seen last time also. It is again VSD with large left right shunt. I just wanted to make it very clear. That's why I had put 2 slides. So you should not confuse LRTI. You should not confuse large shunts with moderate shunts. You should not confuse large shunts with ASD kind of benign shunts. So I think this kind of X-ray you should remember, and it will be very much diagnostic itself. You can get it confirmed with echocardiography, but this X-ray itself is diagnostic. Next.
I think here, just for the sake of the students, Dr. Divyesh.
Yes, sir.
You know, X-ray is just to start the viva after this interpretation. And they will ask you so many questions. I think for that reason, the student should be ready. Here, simply, if I ask you only one question, most we say that VSD may close even spontaneously by its own. You can wait even. So when actually you will submit the patient for surgery at early, even as he has shown one child operated at 5 months with the clips he has shown. Point is, commonly we say that VSD can go even for the spontaneous closure. We can wait. Then each patient, you may have to submit the patient early for the surgery. Clinical pediatrician, you know why I'm asking? Here we want to make even the general pediatrician should know. Suppose if you are following any patient of VSD already diagnosed, then what points you should follow, what you should note it, and from which you can decide even that this is not satisfactory, and I think I should request the cardiologist again to reassess and whether it requires the early intervention. So that's the thing. How will assess on the follow-up?
Sir, QPQS ratio of more than 2:1.
One episode of congestive heart failure is an indication of surgery, and even if the patient is not gaining weight, there's failure to try.
One by one. Just let the Gunjali finish. Gunjali, any patient of CCF will submit for the surgery?
Yes, sir. It is an indication to operate.
Suppose if you are able to manage with even medical line of the treatment, patient remains in the good shape, even there is no recurrent respiratory infections, even child is able to take the feeds fairly good, may not be totally normal, and even gaining the weight, then I think you may not submit the patient. But the point is refractory CCF. That your medical line fails to manage the patient of the CCF. Of course, and as you said very rightly, in spite of all these efforts, even there is no weight gain. Right, persistent refractory CCF. Weight gain is not even the responding. You know, previous criteria, I remember that was a fight between the pediatrician and the cardiologist, that you give the weight 10 kg, then I will operate. But how this child is going to gain the 10 kg? That's the problem. Of course, now with this deviation, all the pediatric cardiologist and even CT surgeon, these things are changing. So the point is, we have to keep in mind that how we have to follow the patient, that clinically, of course, later on you can go for even the investigations like X-ray, ECG, or even the echo point of view, and you can decide whether can we wait or should we submit for the surgery. So I think that's the point which you should take it. Anyway, Dr. Divesh, please go ahead.
Yes, sir. Next slide. Dr. Shailusha.
I think in X-ray also never jump for the diagnosis. Try to see that what you are able to see, your findings, and then try to put all the findings together and then try to derive that what various possibilities can give this type of shadow. So always think in this way. What I am asking always to the students, is X-ray normal or abnormal? Kunja, normal or abnormal?
Sir, abnormal, sir.
Okay, now second question. I think always keep the thought process in this way. Abnormality where? Whether it is with the heart, lung, or even the upper abdomen. Where you are able to see the abnormalities.
Sir, we can see an abnormality in both the heart and the lung.
Okay, mainly in the heart. I think other abnormalities which you are able to see probably maybe the secondaries. Then what abnormalities you are able to see in the heart? Think in this way.
This X-ray shows a massive cardiomegaly around.
Okay, I think that's why Dr. Divya started in his introduction that what we should see in the heart. Absolutely, one is according to you. At least I think let us put your findings. Then we'll go to Dr. Divyesh. He will refine us. As you said, cardiomegaly. Okay, what next?
It is a very large cardiomegaly of around 80%
Okay.
space.
Yeah, it is
there
almost
is,
almost touching the right, even the thoracic cage. Sorry,
yes,
left.
sir. The left, there is
Yeah.
left ventricular enlargement, and the apex has almost obliterated the left costophrenic space.
Okay, what next?
Sir, there is enlargement of the right atrium. There is prominence of the right heart border.
Okay, anything on this beyond the right atrium? Are you able to appreciate your beyond the right atrium?
There is hyperemic lung fields.
Okay, then look at this even upper mediastinum. Any fullness on the left side? What it could be? Which structure must be fulfilling it?
Sir, the left atrium.
I think that also Dr. Divya showed already to us that usually it should be the concave, right?
Yes.
Pulmonary artery or even the left atrial appendices can fill up the gap, and that concavity may get obliterated. Here, rather than the concavity, obliteration of concavity, it has become the wax. Am I right?
Yes, sir.
So which structure may be responsible for that?
It is the pulmonary veins returning the blood which are distended.
Okay, try to keep all these points in your mind. What is regarding the vascularity in the lungs?
There is increased vascularity. There are hyperemic lung fields.
Okay, are you able to see the lower border of the right side of the heart? There is some I would say very sharp cut shadow. How much importance to be given, I'm also not sure, but at least is seen.
Is this silhouette sign, sir?
Now, if you put all the points together, what can be the cardiac problem? Is it congenital or acquired? Think in this way. If it is congenital, what is the likely problem? Cyanotic or acyanotic? Suppose acyanotic, then what type of the? Whether it is related to some shunt or some valvular, and try to explain and put even the various possibility. You know, nobody knows the from the X-ray from day one, but what you see, you are trying to analyzing it. I think just sensitize you. Now, I think Dr. Divesh will take it and he will give these exact findings and explanation. Please, Dr. Divesh. This is just to give that, I would say, insight to the students that how they should think. Please.
So this is a 3-month-old baby with some dysmorphic features, and child is having weight of 3.2 kg. Birth weight was around 2 kg. Birth weight was around 2.7 kg, and now the weight is around 3.2 kg at 3 months of age. Child is having episodes of suck cycle according to mother. Child is not gaining weight also nicely, and you are getting this X-ray. So what is the probable diagnosis?
I think first, Dr. Saluja, what I will suggest you confirm the findings with Dr. Divyesh so that we can learn.
So there is cardiomegaly with left ventricular enlargement, right ventricular enlargement, hyperemic lung fields with a prominent pulmonary knuckle.
And
Left atrial enlargement.
Now, if you recollect the previous X-rays, were you able to get this much L enlargement in any of the previous X-rays?
No, sir.
Compare with the last X-ray. See this. See this.
Yes.
So what is the difference here? Why this left atrium this much enlarged?
Sir.
Child is having dysmorphic faces.
Endocardial cushion defect in Down syndrome.
Very good, Kailash. So whenever you get this kind of cardiomegaly, you see huge left atrium also. So in endocardial cushion defects, what happens that shunts are happening at two levels. There is large ASD also, there is large VSD also, and most of the times patient will be having some AV valve regurgitation also. So this patient was having large VSD, large ASD, and patient was having moderate to severe left-sided AV valve regurgitation. So because of that, you were able to see huge left atrium in this X-ray also. If you count the ribs, if expert examiner is there, no, they will want to know the rib count also. It had happened with my PG days that they were very fond of that if the residents, if the candidates are counting the ribs also. So if you count the ribs here, there is absence of 11th rib. So that's why I had selected this X-ray with large left atrium, and I told 2-3 times, patient is having dysmorphic faces, patient is having dysmorphic faces. So that was the clue to diagnosis. Child is having endocardial cushion defect or AV canal defect with Down syndrome. What is the most or accidental cause of death in Down syndrome?
Atlantoaxial subluxation.
Very good. Very good. And what is the most common cause of death in Down syndrome?
Repeated respiratory tract infection.
Heart. So cardiovascular system is the most contributing factor for the. So whenever the patient comes with Down syndrome and AV canal defect, we counsel the parents with this thing only. If you correct the heart, at least life will be saved. Rest of the things are going to happen. Rest of the things are going to be there. But if you take care of the heart, then this part will be saved. What is the percentage of the Down syndrome who will have endocardial cushion defect?
For 40 to 50% cases.
Very good. So for 40% patients would be having heart defect, not endocardial cushion defect. 40% of Down syndrome will be having congenital heart disease, and out of those, 60% will be having endocardial cushion defect. I think I am right. I have not read books for years, but sir will correct it.
No, I think this is also very common. As I stated, X-ray, ECG, or some instrument is just to start the viva and to assess your knowledge. regarding suppose these are the X-ray or something, and if you come to know endocardial cushion defect or some CHD, as Dr. Divesh mentioned, these will be the common questions in the viva. What number one, in how many children of Down syndrome congenital heart disease is possible? That means what is the incidence of congenital heart disease? Then they will say mention in the order of sequencing the congenital heart disease, which is most common, which is the less common, and what are the others. So in that sequence also, and therefore what Dr. Divesh said is absolutely right. All the Down syndrome may not have the congenital heart disease. And you know, prognosis also depending upon the associated cardiac malformations. The child without cardiac malformations and fairly good other immune system, Down syndrome is having the good prognosis and even the expectancy of the life. But having the congenital heart disease, and that too, even the suppose that you can say endocardial cushion defect is more. That is second is the atrial septal defect. Third is even the VSD, and later on any congenital heart disease can occur. And it depends upon that what even the problem and even how you're able to manage. Because you know, later on at the end, in that case, you know the Down syndrome is the most common condition for the MD examination. Short case, you are going to get it. And they will ask you at the end, now you do the counseling to the parents. That's the most common question. And counseling you can do, number one, from confirmation of the diagnosis, that you will have to do with the stereotyping. After that, even associated problems and complications, that is particularly the cardiac, or even the, some other CNS manifestations. And even for the suppose young mother, if she is interested for the second child, what counseling will have to do for the genetic counseling, and even which tests are now available. So many things. The viva questions can be there from the simple X-ray or from the case. I think that thing you should prepare. Divesh, please go ahead.
Dr. Bhadra sir wants to add something.
Yes, yes. Dr. Bhadra, please.
Okay, I think.
Okay, you can go ahead.
Chalo, next. So who is taking this X-ray now? This is a 6-year-old girl, absolutely asymptomatic. She was showing to a routine pediatrician, and that pediatrician was on leave, so she had to go to another pediatrician. That pediatrician picked up some murmur, and he told that child is having heart defect. So they were devastated that we are showing to our routine pediatrician, and he was not able to pick up this murmur. He has not told anything about heart defect. So to confirm it, he got the X-ray done. So let's get the X-ray done. If X-ray is showing something, then we will get the echo also done. According to that pediatrician, he called me that child is having very prominent murmur. And I don't know why the earlier pediatrician had missed this murmur in this 6 years of lifespan of this baby. So I think Dr. Jagdish will take this X-ray.
Come on, I think all of the students should participate. As already I said that you can do the mistakes. Even you can see the teachers are also always doing the mistakes. So there should not be any hesitation.
Dr. Gunjan. I would say whoever is attending this seminar, they all should keep their video on, so we will be able to know whether they are there or not.
The lung fields appear oligamic.
Who is speaking?
Manali.
Lung fields appear oligamic.
Not more than 50% of lungs are seen.
I am able to see vascularity till 50%. Here it's also there. It is not oligamic. You can say it is a normal kind of vascularity, not oligamic, not plethoric.
Yeah.
Okay, what else? It is very peculiar in this X-ray. We have not seen this thing very peculiar in any of these X-rays.
Try to focus on the cardiac shadow.
Sir, the apex is upturned.
Apex is somewhat uplifted. Okay.
Okay.
Pulmonary,
And
pulmonary knuckle is prominent.
Pulmonary knuckle is very prominent in this X-ray. Very good. What else?
Mild right atrium enlargement.
Right.
Okay. So, what else?
Straightening of right heart border.
What is this?
Right pulmonary trunk, main trunk, pulmonary artery main trunk.
Right pulmonary artery enlargement. Okay. So now assimilate all these things. Asymptomatic girl. Very prominent murmur. He was not able to describe the murmur also. I asked him what kind of murmur is that, but he was not able to describe the murmur. And you are able to find almost normal kind of heart. There is no specific cardiac enlargement you are able to pick up, but prominent pulmonary knuckle is there. When this kind of scenario happens, only prominence of pulmonary knuckle you will be able to see.
My pulmonary stenosis, mild.
Post pulmonary valve dilatation.
Very good. So whenever there is mild pulmonary stenosis and there is prominence of main pulmonary artery, you will be able to see this thing. What else? What is the other differential diagnosis? In pulmonary stenosis, if it is that mild, you will not be able to get a very loud murmur.
So one differential can be tetralogy of fellows.
Tetralogy of fellow. Okay. Tetralogy of fellow, yeah. Pink kind of tetralogy of fellow will have this thing, but again, this pulmonary knuckle will not explain. Pulmonary knuckle will not explain that part.
Even Dr. Gunjali, if you say pulmonary stenosis, how will you explain the prominency of this pulmonary knuckle? Due to what other changes you will get it. Otherwise, stenotic murmur, that means stenotic valve, that means this vessel may not be active much. But then how this knuckle is there?
Post-stenotic dilatation.
Yeah, can it be post-stenotic dilatation? And next question, what Dr. Divyesh asked in the, I would say, related to fellows. Fellows, what happens? On the contrary, in fellows, pulmonary artery is not even rudimentary from the function point of view because not getting much blood. So on the contrary, that rather than prominency, you will get the absence of that shadow, right? That should be there. And rest of the other things, I think 6 years without cyanosis, everything you can correlate. Anyway, go ahead, Dr. Divesh, please take it up further.
Okay, so I would give you a few other points. On when patient came to me, I auscultated, and there was a continuous murmur in second left intracostal space.
PDA.
Okay, what kind of PDA will give this kind of X-ray? Size, I am asking.
Small PDA, of course.
Okay, so child was having small PDA. That's why you are not able to see any cardiomegaly here. You are not able to see any increased vascularity here. Because of that small PDA, the murmur was happening at a very particular second left intracostal space only. That's why that earlier pediatrician missed the murmur, because probably he was not. This is a hypothetical situation. I'm not pointing blame towards anyone. But what happens in your busy OPD? You only auscultate at apex and then you leave it. Okay, heart sounds are normal, no murmur is there, but always try to remember, try to auscultate at least 3 or 4 areas of the heart. In this kind of situation, the murmur will happen at a very particular place at second left intracostal. Apart from that, all your heart sounds will be normal. So whenever you find this kind of scenarios, try to do as I suggested. So this patient was having patent ductus arteriosus, mostly small kind of PDA. And that's why child was absolutely asymptomatic at 6 years of age also. Next, This is very interesting X-ray.
Snowman appearance.
Let me speak.
I think one person. Just if you sometime turn the pages of even the book, you will get this type of the shadows.
Supracardiac.
Supracardiac. Dr. Kailash, I think, is going to pursue cardiology. So I think diagnosis is very much peculiar in this kind of X-rays.
But I think
Dr. Kailash has himself landed in the trap. So let me ask you.
Dr. Divesh, before you take it, I'm sure that you will take it more detail. But before that, Dr. Kailash, why not the thymus? To me, it is thymic shadow.
In thymus, there will be typical cell sign and there will be no hyperinflation of lung. Here, sorry, plethora is present here.
You know, the thymic shadow can be of any type. Even it can be cell-separate, even it can occupy the whole mediastinum, even it can merge with the cardiac shadow, it can give the impression to cardiomegaly, so many. So I think thymus, very difficult. That's why I will say
child have some symptom related to cardiac condition. That's why X-ray.
No, but I want only from the X-ray. I don't know these clinical findings of the patient.
Plethora is there.
Plethora present.
Plethora is there. So
cardiomegaly, first thing first. Any times you have any doubt, look at the size of the heart.
But how will you say even this shadow, upper shadow, then okay, for cardiac condition, maybe so many reasons for the cardiomegaly and even the plethora, maybe simple VSD. But I will say this shadow is thymic shadow. Mediastinal shadow is thymic shadow. Maybe with the VSD. Therefore cardiomegaly, therefore even pulmonary congestion or lungs are congested. But the upper shadow is definitely thymus, nothing else. Because it is a cardiac shadow, not a cardiac station, not necessarily always it is cardiac condition. To me, it is Gunjali only thymus. Now disprove me or prove, let me prove. My point is, how will you clear the doubt regarding the thymus?
Lateral X-ray we can do.
Very good. No, always try to define the anatomy. That where the shadow is. And here also, suppose if you are not able to decide, if you go for the lateral plate, I think before the availability of echo, because you know we were trained before when even echo was there. Therefore, we had these modalities, and if you take the lateral plate, if it is the anterior superior mediastinum, it is thymus only. But I'm sure that if you take the lateral plate, the shadow will be the middle mediastinum, and therefore definitely related to the heart. You can take it. I think Dr. Divesh, take it. Sorry for the interruption, but I think that was important for the students. Yes.
So what forms the snowman, Dr. Kailash?
Sir, congested superior vena cava and left innominate vein and left
vertical.
Then again one vein is there.
Vertical vein.
Vertical.
Vein. There are three veins will do that type of.
So what happens? The pulmonary veins form a confluence, and from that there will be forming a ascending vertical vein. So this is the left ascending vertical vein. Innominate vein will form the top of the shadow, and this is the congested or a dilated superior right superior vena cava. The belly will be formed by right atrium, and this part will be formed by uplifted apex because of RV enlargement. One more point I wanted to point when Baldev sir was talking, whenever he was asking how can you differentiate whether it is not a thymus and this is just a
bilateral
VSD. What is this?
Pulmonary hyperemic.
Is this downward shifting vascularity or it is upward going vascularity?
More upward.
Upward.
Yeah. So remember this thing, whenever you see this kind of reticular patterns shifting towards upwards, it suggests towards pulmonary venous congestion. So this is one disease when you will see pulmonary venous congestion happening in the lung. There is one more other pathology where the LV function is hampered, and because of that, LV is not able to push the blood. LV pressure, LV end diastolic pressure will rise. LA pressure will rise, and because of that, you will see all this kind of venous congestion. It is dilated cardiomyopathy. So whenever you see huge heart and you are seeing this all upward shifting kind of vascularity, you can probably tell that patient is having LV dysfunction and patient is not having vascularity because of increased left to right shunt. Okay. So I think.
Yeah, I think.
I'll just add a point here that we should not expect a figure of 8 for first 3 months because it takes some time for the veins to get dilated and to be seen on X-ray.
Correct.
So in the newborn X-ray, if you see, in a newborn with an RDS, if you're suspecting TA-PVC and you don't,
I'll show one more X-ray.
Ignore it.
Yeah. I think Dr. Dipesh, should we go for the next?
Yeah, sir. So this is the snowman. And as sir was asking again,
this is a thymus.
What is this?
Thymus shadow.
So now you are able to differentiate in both the X-rays. There is no venous congestion here.
Yeah.
This is thymus. There is no cardiomegaly here. So these two things are crystal clear. Whenever you find this kind of X-ray, try to look for cardiomegaly. In any X-ray or any doubtful cardiac condition, get an X-ray, and if it is cardiomegaly, you will get a probable diagnosis. Many a times pediatricians from periphery call me that it looks like duct-dependent lesion. I tell them get one X-ray done first. If you are not able to get an echo done, get one X-ray done. If X-ray is showing cardiomegaly, it will lead towards one diagnosis at least. As Dr. Bhadra was telling, this is a newborn, day 1 of life. Patient has landed in ICU with very bad shape. Patient is not maintaining saturation. Saturation is around 60% with O2 with high flow. Patient is intubated now. Patient is on high flow ventilation, HFO ventilation. Saturation is coming hardly 85%. They get the X-ray done. Patient was having borderline prematurity. So now they are planning to give surfactant also. Surfactant is also given. Saturation has moved hardly 2-3%. Saturation is around 88% now. So before starting inhaled nitric oxide, they call me. So I told them get the X-ray. Let me see the X-ray first. So what is happening here? Is this RDS?
No.
What is happening here?
It is a TA-PVC. We have to rule out TA-PVC in such patients, newborn patients having RDS like picture, not improving after maybe surfactant.
Whenever you see this kind of, as I told in last X-ray also, you were able to see typical vascularity in last X-ray also. Here it is very prominent. Here, as Dr. Bhadra sir told, you are not able to see figure of 8 here. So many a times people confuse that figure of 8 is not seen, but as Dr. Kailash was telling, figure of 8 will be seen in supracardiac TA-PVC only. There is other variety of TA-PVC which will present in at birth or immediately after birth only with this kind of scenario where patient is in stormy course and patient is not maintaining saturation. So this is infracardiac obstructed TA-PVC. If supracardiac obstructed TA-PVC was also there, then also you will see this kind of X-ray, but there will be some prominence of superior vena cava. Here, everything is below the heart, so you will not see any prominence. And as patient is just born, you will not see any huge cardiomegaly also in this kind of patient, because most of the times patient will be hypovolemic. So because of hypovolemia, your heart size also will be underestimated. Patient will be in most of the time shock only. So you see this kind of X-ray, you see many a times you will be confused because of there will be this borderline prematurity, or they will say there was some meconium, but don't get confused. If you are seeing this kind of congestion where upward shifting vascularity is there, try to get an echo done to rule out infracardiac TA-PVC. Okay, next. What is happening here?
Globular heart.
We are seeing all globular heart only. Don't start your viva like this, globular heart. Your viva will be shifted toward globular.
Cardiomegaly with increased pulmonary vascularity.
Okay. What else?
right atrial enlargement and also left side, left ventricle enlargement is also there because the apex is shifted to outwards and downside.
Okay, now I will give you brief of this patient. This is 5-day-old newborn. Child has come to you with complaints, brief complaints of some difficulty in feeding. Pediatrician recorded the saturation. Saturation is coming around 80-82%. He is telling child is not having distress, but saturation is not picking up. On asking mother, she told, it's okay, but feeding, I found it problematic. Child is not able to feed well. You get the X-ray done, and this is the X-ray. Now, anything changes after the history part? Whether it is cyanotic CHD
Cyanotic
heart.
Cyanotic CHD. What is the most common cyanotic CHD which will present at birth?
Yeah.
TGA.
Huh?
TGA.
What is the shape of this heart?
Egg.
Egg.
Egg on its appearance.
Chalo, Dr. Kailash will tell how egg is formed.
Sir, right side there is enlargement of right atria, with that will give a convex border. On left side there is a enlargement to give.
That happens in all the other X-ray also. Why?
Due to back end flow of atria and ventricle give tailing.
Yeah.
That will
Very good.
They are superimposed anterior posteriorly.
So the arterial pedicle which we see in normal X-ray is lost here because great arteries are positioned anteroposteriorly. So that's why you will lose the arterial pedicle that is formed in the normal X-rays. So that's why
tailing is appear.
Yeah.
Dr. Divesh, should we go for this session?
Boot shaped heart.
Chalo, I will just spotters. Okay, what is this?
Boot shaped heart.
Tetralogy.
Tetralogy.
What is this?
Box shape.
Box shape. What is the disease?
Epstein's anomaly.
Epstein anomaly. What is this?
I think with that, where the Epstein was first reported in India. Anybody? Epstein anomaly was first reported in India from which place? And you know, Epstein can present in a different way, very serious newborn with cyanosis and arrhythmia, even the adult without any complaint. Incidentally, X-ray chase showed the huge cardiomegaly and right atrium and diagnosed. Epstein anomaly, for your information, you can check even the history, was first diagnosed from BJ Medical College, Ahmedabad. And that was somewhere in 1962 or 63. That was a post-mortem diagnosis reported in Indian pediatrics of that time. Just for the sake of general knowledge, but I think please go ahead, Dr. Divesh.
Chalo. What is this?
Pulmonary oligemia.
Oligemia.
Yeah.
What else?
Cardiomegaly and
pulmonary
stenotic dilatation of maybe due to.
No, not. It is not. Whenever you see prominent pulmonary knuckle, it is not always post-stenotic dilatation. It can happen because of post-stenotic dilatation. It can happen because of left to right shunt. It can happen because pulmonary artery are enlarged because of chronic left to right shunt. So whenever you see low vascularity, oligemic lung fields, no cardiomegaly and prominence pulmonary knuckle, it is Eisenmenger syndrome. Okay. What is this?
Dextrocardia.
Situs inversus totalis. You are able to see some bubble here. What is this?
I think in the previous X-ray, one should see that lower part of abdomen should be taken properly.
It was not there, sir.
It's not seen properly. So that's very important, that lower part of abdomen. Look at this viscera of abdomen.
What is this? Huh?
Very
good, Dr. Kailash. It is leather bottle appearance.
Yeah.
Why it is formed? Because of the fluid shifts downwards and it enlarges the lower part of the heart rather than upper part of the heart. What is this? So everything is not about heart.
Pleural effusion.
I just put this X-ray to confuse you, because once you keep on seeing the heart, no, you will miss the other parts also. As sir told, it is not always about the heart. As this session was about heart, but try to see other parts also in the X-ray. Thank you.
Anyway, I think before we go for the session, for the sake of the students and those who are interested probably for the future cardiology, like Dr. Kailas, I think, yes, Dr. Divesh was pointing out and maybe right. So it is said that if you are pediatric cardiology, you know the embryology, how the heart is formed, and what are the defects of heart which manifest in the form of the congenital heart disease. And for that reason, first you should know the anatomy. After this anatomy, you should know the very important aspect, circulation. If you are knowing exactly the hemodynamic circulation, everything, you can explain that why the left-sided heart in a case of VSD and why this right-sided heart in a case of ASD, or parestheticology, these type of oligemic lung pain, everything, any manifestations you can explain. So hemodynamic circulation is the basic for understanding the every aspect. Later on, I'm sure that you must have the NADAs in pediatric cardiology. Was coming from a very ordinary family from Hungary, and once even he was not allowed to work in cardiology during those time I'm talking. Later on, he proved his efficiency, which we are learning at present NADAS criteria. And at that time, NADAS has commented good physical examination, basic good X-ray was Dr. Divesh discusses with, I will say, more details. What Dr. Patra is going to discuss the basic ECG. These are the three important pillars for clinical diagnosis. Now with the advanced technology, we can go for the confirmation with echo, or I will say advanced facility available to us. But I think the sad story which I want to convey to you, because you are going to be the future clinicians, even the specialized people, don't specialization at the cost of basics. Otherwise, what happens that it becomes very dangerous. Even I'm sure that both the cardiologists will agree with me that being the cardiologist, you have to go in the details of the history, examine the patient in details, go even with the basic, I will say, investigations, and then echo. Not necessarily every time echo will give you the answer. Even occasionally it may happen so that it may confuse you. But if you have gone methodologically, probably you will be on the right pathway. So that's important, that never compromise the basics of the history examination, say clinical diagnosis, later on X-ray ECG, that what configurations and shadows are, and then putting some of the possibilities and echo for confirmation. And still it so that after this echo we submit the patient for surgery, it usually even some complexity or even the multiple malformations or even the different story. So this is very common. So the point which I wanted to convey, that please be the first clinician, then go for the advanced technology, and I'm sure that that will teach us a lot. Thank you very much. I think Dr. Divyesh made the session of cardiology very interesting and very useful to all of us. I also learned many things, and I'm sure that it is going to be useful to all of us. Now, second part of the session, and I'm sure that ECG, which are usually commonly, I would say, neglected or missed by the general pediatricians, but equally important. Dr. Bhadra, you can take it, please. Thank you very much.
Sir, are you able to see my slides?
Yes, yes.
Yes, sir. It is very, very nicely seen. You are audible.
Yeah, so I'll just add a point to what you were saying, sir. I completely agree that echo is not the final tool because it will not tell us anything about the lungs. So that we go for X-ray and then electrocardiogram for electrical activity. Because finally we want to treat a patient rather than just a cardiac part. So me and Divesh both follow the same practice as everybody else that you have to see a child in toto, examine, go X-ray, ECG, finally echo, and then make a plan. So all are part of it. Yes. Uh, Now for my session, I thought because it's in the form of table viva and there are 5 residents around, so I have created 5 blocks, one for each resident. So my plan is to share some slides for introduction and then ask one resident a question regarding that slide. That's what I was planning, sir. But you can always improvise, sir. Whatever you find it best for them.
Just Dr. Petra, before you start, please consider me. After some time, I'll have to leave with some other, I will say, commitment. So please consider me. I will leave after a few times. I think it's 5-10 minutes, please.
Fine, sir. Sure. So I'm affiliated with Karam, sir. I'm a pediatric cardiologist there, and I'm with the Department of Pediatrics there. And for all this future, probably potential pediatric cardiology here is pediatric cardiology is more closer to pediatric than the cardiology. So you are in right spot. So I'll start with my presentation. So a normal ECG examination should include rate, rhythm, QRS axis, T axis, but we are going to skip this part because the table viva. I don't want you to get carried away with the whole details. So this block, I'm going to ask Kailash few questions. Kailash, are you there?
Yes, sir.
So I'll run few slides and then I'll ask you a question. Okay, Kailash?
Yes.
So the most important part which I feel is the vectors of an ECG. So ECG in which we have leads and the vectors. Leads is basically, vectors is basically a flow of current. If the current is flowing toward the leads, it's going to give a positive deflection. If it is flowing away from it, it's going to give a negative deflection. If the flow is stronger, it's going to have a higher amplitude. If the flow is weaker, it's going to have a smaller amplitude. Just yeah. So we have two types of system. To pinpoint any structure in the body, you need three-dimensional orientation. So to do that, we have two different axes. So if you're able to see my cursor?
Yes, yes, it is seen.
Yes. So in this one, we call it limb leads. So limb leads are 6, they are hexaaxial, and they will give you an idea of right, left, superior, inferior. It will not give you any clue about anterior and posterior. So for the anterior and posterior, we have V1 to V6 chest slits. Pinpoint any chamber, you need both together, whether it's the right side or left side, or it's an anterior or posterior. This is an Anton-Wann's triangle. So if the easiest way to remember a lead is, remember lead 1, which is like a 0, it's a horizontal lead. Lead 1, you start with a clockwise. You go clockwise, the first leg which comes is a lead 2. Second leg which comes is a lead 3. The lower part of the heart is given a positive denomination. So lower part is from 0 to 180 degree, with the lower part is 90 degree. The upper part is minus 90 degree. And similarly, when you go from V1 to V6, V1 and V2 are anterior leads, 3, 4, 5 are lateral leads, and V6 is posterior leads. So this is how we are going to calculate an axis. I have seen a lot of my colleagues, they find it difficult to calculate an axis. There are a couple of ways doing it. I'm going to go with the one which I use it commonly. So this is an ECG. You take two leads which are perpendicular to each other. Commonly used leads are 1 and AVF. So lead 1 is this one, which is like completely horizontal, and AVF is completely vertical. So they cross-sect each other at 90 degree. So we'll take this ECG, we'll try to calculate axis of QRS complex. You can use the same method to calculate axis of P wave, same as well as for the T wave. So this is an ECG paper. We are going to plot the whole circle over it with a center over it. You should do it physically. It's easy to do it. So now next thing we are going to do is we are going to calculate the net deflection of QRS complex on a lead 1. So in this lead 1, the R is +8, which is going up, and S is -3, which is going down. So the net deflection is going to be +5. So now lead 1, as we know, it is 0 degree. It moves from this side and goes from right to left. So this side is going to be plus. We are going to plot this +5 somewhere over here. So we have one axis. Now we need second axis. So for that, we are going to use AVF. So in AVF, the net deflection is positive in R is +9, and we don't have any S wave. So it's 0. So absolute net deflection is +9. Again, we are going to plot this on the chart, and it's this. So this cross section is going to be your axis. You should follow this. It's simple and it's doable for all complexes, QRS complex, P wave, and T wave as well. Easy way to remember is that if you use lead 0 and AVF, is going to be a quadrant which is 0 to 90 degree. If the leads are positive in 0 and AVF, it's going to be in this quadrant. Suppose you don't get a good lead which is positive or negative, you get a lead which is biphasic. So in cases of biphasic lead, your axis is going to be perpendicular to this biphasic lead. For example, this particular ECG, the lead 2 was completely biphasic. So lead 2 is this one. So the perpendicular to this is going to be AVL. So your axis is going to be on the line of AVL. This will come with a practice. There's a normal values. If you see this, for the first 1 month is going to be +110 degree. For rest of that 1 month, is going to be in normal quadrant, which is 0 to 90 degree.
No, it was the outside.
From 50 to 70 degree, but other than first 1 month is going to be all normal axis, which is positive in lead 1 and positive in AVF. Okay, so Kailash, this is a question.
Yes.
You have to tell me whether this axis of QRS is in normal quadrant or not. So this is the whole ECG. This is lead 1 and this is lead 2. So I'll give you an ECG paper. How are you going to plot this? What will the absolute net deflection in lead 1 for QRS complex?
The net deflection in lead 1 is positive, and also in AVF also it is positive, so it is in 0 to +90 degree.
Yes, so that's fair. That's a fair idea. You don't need to go in a lot of nitty-gritty if your axis is mostly normal. This look, the axis is going to be around 30 to 40 degree, which is normal. This is how we calculate axis. Okay, Kailash. Now this is the next ECG. So these are all ECG. This is your lead 1 and this is AVF. Now how will you calculate axis in this? You tell me what is the net deflection in lead 1?
Lead 1 net deflection will be negative because negative minus okay, negative.
So where will you plot this lead 1? So where will you draw a line for -5?
This side means -90 to -180 degree. This okay.
So am I right? What I have done is right, or should I correct this?
No, sir, right, but
okay, fine. Now Kailash, tell me the axis of AVF.
Net deflection positive around 13. Positive.
Yes. So where will I draw a line of positive AVF?
Below.
Good. So
-90 to +90 to 180 degree.
Yeah. So what do you call this? This is a right axis deviation. So it can be tautology of fellow, it can be ASD, it can be triatrizia at times. There are various diagnoses. This can be right bundle branch block. And this is how you calculate axis. Okay. Similar axis can be calculated for P wave as well. Okay. Kailash, you are done. So now is Gunjali here? Is Gunjali online?
Yes, sir.
Okay, Gunjali, this is for you now. This block is for you. So how do you define sinus rhythm? So for sinus rhythm, you need to bear two absolute requirements. One is your P wave has to be followed by QRS, or each QRS complex has to have a P wave preceding it. This is absolute requirement number one. Second requirement, your P wave has to have a normal axis. So for P wave to have a normal axis, it has to be from 0 to 90 degree. So as Kailash said, if the lead is positive in V1, if the lead is positive in 1, and AVF is going to be in that quadrant. So you need a P wave which is positive in lead 1. You need a P wave which is positive in AVF to call it sinusoidal. Now, textbooks differ in this PR interval. Certain textbook feel that if the PR interval is longer and it goes in a range of heart block, it's not considered a sinus rhythm. Other textbooks say that if it is first degree heart block, though the PR interval is prolonged, it is still a sinus rhythm because all QRS is preceded by the P wave. So for our example, what we do, we say P, QRS, if they're following it is sinus rhythm. If the P is positive in lead 1 and AVF, it's a normal quadrant. Irrespective of PR interval, I'll call it sinus rhythm. Okay, so this is the SA node. SA node sends a signal and it travels to AV node. So this is the direction of flow. So this direction of flow is going to be positive in lead 1. And because the AVF is in this direction, it's going to be positive in AVF as well. It is going to be normal axis of P wave, which is 0 to 90 degree. So this particular example is known as lower atrial rhythm, where your AC node is situated much lower. If the AC node is much lower, your depolarization of left atria is going to go away from AVF. So if it goes away from AVF, the P wave is going to have a negative deflection. See here, this P wave in AVF, which is negative. You see here, the P wave in AVF is positive. Again, lead 1 is baseline. So if you see the lead 1 is baseline because it's not crossing it. So in this case, though the QRS is preceded by the P wave, it is not a sinus rhythm because P wave axis is abnormally here. Okay, Gunjali, is this a sinus rhythm? What are the components of sinus rhythm?
So in the lead 1, there is a positive deflection in the P wave.
Yes.
And in the lead AVF also there is a positive deflection. So the axis for the P wave is in the 0 to 90 degrees. So it is a sinus rhythm.
What are the other characters?
P wave is preceding every QRS complex.
Yes. So the both are met. So this is sinus rhythm. Fair enough. Now, is this a sinus rhythm?
In the lead 1, there is negative deflection in the P wave, and in the lead AVF there is a positive deflection. So this indicates that the P wave comes in the left. There is left axis deviation.
Why you say left axis deviation? Let's calculate P wave axis. Okay, should be usually. So
Yes.
this is lead 1.
Yes.
Right axis deviation.
Right.
We'll come
Sorry,
to that.
right axis deviation. Yes.
Don't worry, it's okay. You can either have a left or right. So 50% you are right. Don't worry about that. So this is lead 1. This is lead AVF. If lead 1 is negative, which half you are going to be in?
In the opposite side, sir.
In
On
the opposite,
negative.
Opposite side of the lead 1.
If the AVF is positive, which half you are going to be in?
Towards the AVF side.
Yeah, so this is your quadrant.
Yes.
So when can you have depolarization of atria in this direction? Is completely mirror image of normal?
Situs, maybe when there is situs inversus.
Yes, you got it right. So this situs inversus. Okay, so this was an ECG of situs inversus. So now, do we have Satakshi with us?
Yes, sir.
Okay, Satakshi, can you hear me?
Yes, sir, I can.
So this block you will have to answer at the end of it.
Okay, sir.
So we are going to talk about atrial enlargement. Now, atria, the wave which we focus is P wave. Okay, so the P wave has two components: the first part and the second part. The first part is made up of right atrium. Second part is made up of left atrium. We should look for P wave in two leads, leads 2 and V1. The two leads we will describe a P wave for. So if there is a right atrial enlargement, like here, the first part is going to grow taller in lead 2 and lead V1. So this tall P wave is known as P pulmonar. Because it's like P wave. if your LA is enlarged, because your current will have to travel much farther into the left side, is going to get stretched. So if it gets stretched, your lead 2, the P wave will be of M size, M shapes, it's known as a P mitral. V1 is going to be biphasic. So this is what you remember for P wave enlargement. There are certain criteria for this. If the P wave is taller than 3 millimeter, 3 millimeter is 3 small squares. It is right atrial enlargement, and you are going to have taller P wave in lead 2 and lead V1. So tall P wave is P pulmonale, and P pulmonale is right atrial enlargement. You see that in TAPVCs, you see that in all types of ASDs except primum. Let's talk about the other part of enlargement, M mitrale. So this was about the amplitude. If it is more than 3 millimeter, it's going to be P pulmonale. If it's going to go horizontal, we are looking at the speed. One small square is going to be 40 milliseconds. So if it is more than 100 milliseconds, 0.1 second, is going to be roughly 2.5 small square. Now it's difficult to see 2.5 small squares. So again, you take it as a 2 plus small square, so 3 small squares. So if it's 3 small square horizontal, it is M mitral, or if it is biphasic in lead V1, it is M mitral. M mitral means your left atria is enlarged. You see that in VSD is very common. Okay, Satakshi, this is an ECG. Tell me, what do you see in lead 2 and V1 for P wave?
So for P wave in lead 2, sir, I can see width has been increased and
Yes.
M-like pattern is there.
Yes.
And in V1, biphasic P wave can be seen. So it's P mitral. So and
so this looks like a little left atrial enlargement.
Left atrial.
Okay. Now this ECG, tell me about the P wave in this ECG.
Sir, in this ECG, in lead 2, we can see that P wave has increased. That is more than 3 small square, and in V2 also approximately more than 2 to 3 small square.
You say lead 2 and V1.
V1, sorry, V1 also more than 3 small square. So it's mostly P pulmonale. That is right atrial enlargement can be seen.
So this is how we define right atrial enlargement. Now you can relax. Okay. So this for the QRS complex. Next, who is left? Is Shailusha online? Shailusha or Manali?
Yes, sir.
So who was it? Manali?
Yes, sir.
Fine. So Manali, this block is for you.
Yes, sir.
So this has to do with conduction. So this is some basic information which I'm running through. So the current flows like this. It starts with an SA node. Then current will reach, first it will depolarize right atrium, then it will go into left atrium. Some amount of current which reach AV node earlier. Now because there is a block, it cannot immediately transmit to ventricle because the atria has to completely get depolarized first. So that they start contracting in the lateral diastole and they start pushing blood into ventricle. So even though the SA node is very close to AV node, the current is not going to go through ventricle because there is this block here. Now on this chest, this is a chest. So we have kept 2 leads. One is V1, another one is V5. V1 is going to capture, both the leads are going to capture all the currents. But the currents which are flowing towards V1 will come as a positive. The current which are going away is going to be negative. So if you see the P wave is strongly positive in V1. This part which is going away, which is terminal part, is negative. But when you see V5, in V5, all the current is flowing towards V5. So V5, the P wave is completely positive. Number 2 is the septal depolarization. Now, because the septum is more prominent on the left side, it depolarizes from left to right. Now this vector which is left to right is directly facing V1. So the first ventricular depolarization in V1 is going to be positive wave. So it's going to be R wave, which is positive, first positive deflection. V5 is staying away. So because the V5 is staying away, there is going to be a negative deflection because this QRS current this across the septum is going away from V5. So though this R is positive in V1, similar current is negative in V5. First negative wave in ECG on QRS complex is Q wave, which is negative. Now let's talk about main ventricular polarization, which is R wave, which is tall R wave. Now this tall R wave is very small because most of the current is made up of left ventricle. The left ventricle wall is very thick. Now where the left ventricle is all going towards V5, is going away from V1. And because it's all going towards V5 and away from V1, all you see is negative wave in V1, which is like a deep S wave. While you see a positive wave in V5, which is like a tall R wave, which is QRS complex tall wave. So this shift from V1, where you have small R wave and big S wave, to a shift in V5, V6, where you have tall R wave and small S wave, is known as transition. Transition happens from V1 to V6. This is known as normal transition. This transition will give us an idea about right ventricular hypertrophy, left ventricular hypertrophy. For left ventricular hypertrophy or right ventricular hypertrophy, as I said, we need to take two systems in place, two systems to assess. First one, which is limb leads. The limb leads will give us whether it's a right-sided chamber or left-sided chamber. So if it's a right ventricular hypertrophy, we'll see leads more on the right side getting taller R wave and smaller S wave. If it's a left-sided hypertrophy, we'll see leads on the left side having taller R wave and smaller S wave. Again, we can have an anterior and posterior dimension. If the anterior ventricle is hypertrophied, which is right ventricle, you're going to tall R waves in right side, and you're going to small S waves in right side, which is like a V1 and V2. If there is ventricular hypertrophy on the left side, you're going to have tall R waves and small S waves in V5 and V6. So based on these, we are going to define whether this is a right ventricular hypertrophy or left ventricular hypertrophy. So all you should remember is which leads are representing right side. So which leads which are representing right side are V1, V2, 3. So these V1, V2 and lead 3 are right-sided leads. AVL 1, 2, 5 and 6 are left-sided leads. You look for the ratio of R wave and S wave. Just look at the ratio of R wave and S wave. Is your R by S ratio is more in V1 and V2, or it is less in V5, V6? That means your S wave is much bigger in V6. Means all the current is going away from V6. You're going to right ventricular hypertrophy. For the left ventricular hypertrophy, your R by S ratio is going to be significant for V5 and V6 because all the currents are going toward the left side. While you will have small R by S ratio in V1 to V2 because there is no current that side. It's all gone to the left side. So this will give us some idea about whether it's a right ventricular hypertrophy or left ventricular hypertrophy. There are a lot of other criteria as well, but we are not going to go through this. Manali, can you run through this ECG? What do you see in this ECG?
Well, we can see in V1 the negative deflection, that is S wave is prominent.
Yes. So what does it mean? What can you confer from that?
It is going away from that lead.
Yeah. So what is away from V1? Which ventricle is farther away from V1?
So it is RV, it's going away from RV towards LV.
Fair enough. So
also in V5 and V6, we can see the prominent R waves. So that R by S ratio will be more prominent. So it is indicative of LVH.
Yes, it's more like left exit deviation in LVH because you see the tall R complexes in V4 and V5. You don't see any S wave. Why you don't see any S wave in V4, V5?
So because there was that gap.
What will create S wave in V5 and V4? Which ventricle will represent S wave of V5 and V4? V5 is situated where?
Left
Posteriorly?
Left side.
left side posteriorly. So it is closer to which ventricle?
Left ventricle.
It is away from which ventricle?
Our right ventricle.
Right ventricle. So if you don't see S wave here, that means you're away from right ventricle, and you are away from right ventricle, but there is no right ventricle current. It's all left ventricle current. So this is left axis deviation. Okay. So go to the next slide. Okay. What do you see here?
Prominent R waves in V1 and V2.
Yes.
But in V2, the S wave is also prominent. And in V5 and V6, prominent R waves.
But you also have deep S waves, right?
Yes.
So why you have deep S wave in V4 and V5?
Because some current is flowing towards right ventricle as well.
Yes. And you have
Right
tall
ventricle.
V1. Now which are these two leads? V3R and V4R?
So these are the mirror images of the V4 and V3.
So these are equally tall, right? These
Yes.
are equally tall. So which ventricle is creating a lot of current in this patient?
Right side. Right ventricle.
Right ventricle. This is right ventricle hypertrophy. Now, common mistake we make is that once you have this ECG, and generally we don't take V3R and V4R.
Yes.
We end up thinking that no, because V5 and V6, V4 and V5, you see tall R wave and small S wave is still left ventricle which is dominant, because generally we don't take V3R and V4R. But we don't put leads there, so we don't capture them. Now, if you put leads there, you can make out this tall R wave, which is on the right side, are more taller than V4 and V5.
Yes.
The dominant ventricle is right-sided ventricle. So this is right ventricle hypertrophy. Okay. So these are certain things which you can put it in your clinic to remember, but these are not very accurate. These are more for adult, but for us, localizing R by S ratio is fair enough. You don't have to go through all these things. I'm going to skip this. Okay, so this is a T wave. You will get a lot of queries for abnormal T waves in an ECG for a child who is undergoing any type of surgery or any type of anesthesia. They will take an ECG lead and they will ask for your opinion that, okay, the T wave is abnormal, what to do with this? So you should remember this slide, this one slide is this okay. T wave is all seen in V1 to V6. I'll start with the V5. You should just remember this slide, and this should do your all PSC part for abnormal T waves, which the machine will report in a pediatric age group. For all V5 and V6, T waves are upright at all ages. They cannot be inverted. If the T wave is inverted in V5 and V6, don't give fitness without an echocardiogram. Very few babies will have flat or inverted in first 3 days, but if you see an inverted T waves in V5 and V6, get an echocardiogram before surgery, before any fitness. When it's come to V2 and V3, for first 3 to 5 years, they are going to be inverted. Then it starts growing up. So by 3 to 5 years, 40 to 50% will have, 50 to 60% will have inverted T wave. By 8 to 12 years, only 10% will have inverted T waves. So if the child is 8 years or more, and if you have inverted T waves in V3 and V2, it is abnormal. They have to be positive, V2 and V3, okay? V1 and V3R, we don't capture V3R very often. So let's just talk about V1. First 3 days is going to be upright. 3 to 7 days, it can be equiphasic, it can be positive or negative. 7 days onward, it has to be negative. It cannot be positive. For 7 days to 1 month, it has to be negative. Gradually, it will turn up. Gradually, it will start reverting back to positive. And by 12 to 16 years, it will be positive. So I'll again summarize the whole thing. If you see V5, if you see inverted T wave in V5 and V6, don't give fitness without an echocardiogram. If the child is more than 8-year-old, if you see inverted T wave in V2 and V3 as well, don't give fitness without an echocardiogram. V1 is there are a lot of things there in V1. Okay, now who is remaining? Do we have Sailusha here? Who is there from Karamsad?
Yes, Sailusha is there.
Yes, sir. I'm
Yes.
Okay, Sailusha, this is the last one is for you. Okay, so we are going to discuss about heart blocks. So this is an ECG print, ECG later. one small square at 25 mm per second speed, which is like a standard speed, is going to be, one small square is going to be 40 milliseconds, which is 1 mm. You combine whole 5 mm together, is you are going to have 200 milliseconds. And on vertical axis, one small square is 1 millivolt. So this is a standard ECG. There's a segment start with the P, ending before the QRS is a PR duration. PR duration plays a role in heart blocks. So we are going to check the heart blocks. So for PR duration, for the heart block, they're going to say it has to be higher than certain limits, and then you call it a heart block. So these are chart which is from Park's Pediatric Cardiology. The way to remember is for first 1 month, if it is less than 3 small square, your PR is normal. That stands true till 3 to 8 years. 3 to 8 years, less than 4 small square is normal. And finally, in adult, less than 5 small square is normal. So 3 small square is going to be 120 milliseconds, 4 is going to be 160 milliseconds, and 5 is going to be 200 milliseconds. This is some rough thing. If you see is deviating beyond this, then you can use the chart to raise a doubt of heart blocks. So the first degree heart block is just a prolongation of PR interval. So you have, so first degree heart block is again considered a sinus rhythm. So it follows a sinus rhythm. That means all QRS complexes are preceded by a P wave. So your P followed by QRS, then your T wave, again P followed by QRS. This PR duration is going to remain stable. It's not going to change. It may be high. It may be higher than the expected. Suppose the child is 8-year-old. It may be 200 milliseconds. So then it is a first heart block, but still it's a sinus rhythm. In second heart blocks, you have 3 different varieties. First one, if you see this PR interval, this is 1 PR interval, then it starts prolonging. Again, the next bit is further prolonged. The P moves towards T wave. And finally, there is no QRS complex. This P wave is without QRS complex. Because this P wave is without QRS complex, this cannot be a sinus rhythm. Then there will be an again P wave, and again it will follow the same. So this is prolongation of PR interval. In Mobis type 2, you don't see this prolongation. There is going to be PQRS, PQRS, then suddenly one QRS will not come. It's just missing. The ventricle is sneeze. It will just not beat. So again, you will have a pause. Then again, you will have PQRS, PQRS, PQRS. Difference between first and second is that PR is variable. In second, PR is going to remain stable. It's just that you will have one peak which is not followed by QRS. All other PR interval is going to remain same. It may be normal, it may be increased, but it will not change. Now, because you have one strip where the QRS is missing, again, it cannot be sinus rhythm. Now, when it's say 2:1, your PR interval, you are going to have 2 P wave between 2 QRS. So this is very classical of 2:1. You have 1 P wave, then QRS, then you have P wave, which is not followed by QRS. So again, a P wave has come, this followed by QRS. So between this QRS and this QRS, you have got 2 P waves. So this is 2:1 heart block. Finally, you have complete heart block. In complete heart block, you are going to have P wave, which is coming independently, QRS complex is coming independently. So you may have a regular PP interval. You may have regular RR interval, but they are not coinciding. So this is complete heart block. So now we are going to have few ECGs for complete heart block. Okay, solution. What type of heart block is this?
Sir, we are able to see a constant PR interval.
Yes. So you have PQRS, 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 and then P without any QRS.
Yes.
So the PR interval is static. So what do you call it?
This is a type 2 Mobitz.
Yes, good. What is this ECG? I have drawn PR interval in a thick marking, so you know that this was the first PR interval. What is happening with this?
So the PR interval is progressively increasing till there is one missed QRS complex.
Yes.
This is a type 1 Mobitz.
Fair enough. Yeah. So now I think
one
a couple of things. Yes.
Sir, we have to see this rhythm in any lead, or we have to see on specifically lead 2 or 3 or any.
No, you ask for rhythm lead, because what will happen is if you don't ask them to take a rhythm lead, your ECG will change after 3 leads. So suppose it is a lead 2, so you have 3 lead 2 beats and then AVL comes. So you can't judge based on that. So you have to have a rhythm strip. What I have marked is wrong. I should have marked it here. What you pointed out is correct. I cannot mark it here. It has to be on a rhythm strip. And you don't need chase leads for this. If you're suspecting arrhythmias, limb leads are good enough. It will give you a good idea. It's easy to take. Chase leads are painful for us as well as for the child. Even the child cries and technician cries and everybody will cry. Limb leads are safer. They're easy to do it. So if you're suspecting arrhythmia, just focus on limb leads and it will give you a good clue. Tell your technician to take a rhythm strip and you will have a good, beautiful rhythm strip. At least there will be a couple of rhythm in between where child is not crying, child is not moving, and you can have some inference from that. Okay. Yeah, so just one more slide, couple of slides. This is for the Alcapa. You may have an ECG sometime where you see a very deep Q wave in lead 1, which is this one. See the Q waves, very deep Q waves, AVL and V3 to V6. If you see this, you are dealing with Alcapa. And Alcapa is a condition where the left coronary is going to come from pulmonary artery. It's a disastrous condition for child, and mostly the child will need an urgent surgery. First clue is going to be a very cranky child who is not gaining weight, who is very irritable, because the child is continuously getting myocardial infarction. Like the one in adult where they have myocardial ischemia, they have heart attacks, they have pain. Similar thing is going to happen with this child. They say this child has multiple myocardial ischemias in a day because the cause is coronary ischemia basically. So if you have an ECG, if you do an ECG of any child, you do not have an echocardiogram or the X-ray is not very good. And if you have deep Q wave in 1, AVL and V3 to V6, you are dealing with Alcapa. So this is something which I wanted to share with you. This one slide and the T wave slide, because a lot of time you will get reference for abnormal T wave from your anesthesia colleagues saying that give a PAC because the T wave is abnormal. So the two things which I wanted to share with you guys. I think I don't have anything more. Yeah, I'll end it here.
Bhadra sir, very nice presentation. You have made it very lucid because pediatrician and ECG reading are oxymoron things.
Yes,
Because
definitely.
many pediatricians are not able to read ECG of their relatives or themselves also. So they just forward these ECGs to cardiologists and ask us what is happening in this ECG. So made it very crisp and very clear for these residents that at least they can do the basics with this presentation. Thank you.
The most common
Thank
my
you.
reference for ECG are abnormal T waves. The T wave is abnormal. Should we send T-tropi? That's what we will start with.
Yes. So thank you so much, both the experts, Divesh Bhai and Bhadra sir. I'm proud. I'm also a GMCS alumni. So
Oh, lovely. The Surat gang
GMC
today.
reunion.
So I am proud both of actually I should not speak junior, but both of my colleagues. So wonderful session. Really, I enjoyed it throughout this session. And I hope all the students who joined and participated, they also enjoyed. So I thank also Sailusha, Gunjali, Tatakshi, Manali, and Kailash for your preparedness to answer everything. Your preparedness to answer everything, because sometimes when ECG is asked, we are always a step back. That no, I don't want to answer about the ECG. But Bhadra sir explained very well, and all the students answered also very well. So I thank all the students. And for Divesh bhai, you presented each and every X-ray. I thought which is left, which is left. I thought Epstein is left, this is left, but no, each and every X-ray, each and every disease was covered. So hats off to you both. Okay, thank you so much.
Hi, ma'am. Hi,
We
Devesh.
can.
Bye. Bye.
Hey, Gujarat Titan
Hello,
on.
ma'am.
Any residents, if you are having any query, I will just
Ma'am,
put
with all your permission, can I share the e-certificates for now, since we are
Yes, please share the e-certificate.
Ma'am, for that reason, I need someone who is sharing the screen. The screen has to be.
Badra sir, please.
I did that.
Yes. Thank you, sir. Thank you. Let me share the screen once.
Yes, so very much thank you for both the experts, Dr. Badra sir, for presenting here, being there as an expert.
Ma'am. There is one more.
Yes. Yes. And thank you so much, Divesh bhai, for being here as an expert.
Okay, ma'am.
Thank you, everyone. Thank you,
Bye,
everyone,
everyone.
for being in the session and sharing such valuable insights. I hope we will be meeting you soon with another interesting topic, another interesting classwork session at our platform. Till then, stay healthy and stay safe, everyone. Thank you. Hope we meet you soon. Good night. Have a nice day.
Thank you. Good night.